Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about B-lymphoblastic leukemia and lymphoma. So let's get started. So this is defined as a neoplasm of precursor lymphoid cells committed to the B-cell lineage, involving bone marrow and usually peripheral blood. When it's involving the bone marrow and peripheral blood, we call that a leukemia. So we call it B-lymphoblastic leukemia. This neoplasm is often involving nodal or extranodal sites as well, which by definition are the primary sites of involvement in B-lymphoblastic lymphoma. So we have B-lymphoblastic leukemia and we have B-lymphoblastic lymphoma. We call it leukemia when the predominant site of involvement is the bone marrow and peripheral blood. And we call it lymphoma when the predominant site of involvement is either nodal site or an extranodal site. However, in cases in which you have involvement of the peripheral blood, bone marrow, as well as extranodal sites, and you can't actually decide which part is the primary, then in that case, the distinction between a leukemia and lymphoma is arbitrary. And that's why, generally speaking, we call it B-lymphoblastic leukemia and lymphoma. That's the name of the general entity. As for the localization, it can involve bone marrow, peripheral blood, central nervous system, testes, lymph nodes, liver, spleen, skin, soft tissues, and other sites as well. So any site in the body can be affected. The clinical presentation is variable. B-lymphoblastic leukemia may present with bone marrow failure, meaning that these patients can present with anemia, thrombocytopenia, and leukopenia and the clinical features associated with these. For example, presenting with fatigue and shortness of breath due to anemia, presenting with recurrent mucocutaneous bleeding due to thrombocytopenia, and presentation with recurrent infections due to leukopenia. So the clinical presentation is actually variable. So it can involve bone marrow failure. Some patients present with lymphadenopathy, hepatosplenomegaly. Some patients present with bone pain and arthralgia. So it's pretty variable. Lymphoblastic lymphoma, on the other hand, is usually asymptomatic at presentation with limited stage disease, including less than 25% blasts in blood and bone marrow by definition. So in the lymphoblastic lymphoma, we call it a limited stage disease if you have less than 25% blasts in the blood and bone marrow. Head and neck presentations of B-lymphoblastic leukemia, B-lymphoblastic lymphoma are common, especially in children. And generally speaking, B-lymphoblastic leukemia is a disease of children in general. It occurs predominantly in children, with 75% of all patients aged less than 6 years. B-lymphoblastic leukemia is the most common leukemia in the pediatric age group, period. B-lymphoblastic lymphoma, on the other hand, represents about 10% of lymphoblastic lymphoma cases, and the remainder being of T lineage, and the majority of cases occur in patients aged less than 18 years. So for the B-lymphoblastic lymphoma, usually patients less than 18, but it only comprises about like 10% of lymphoblastic lymphoma in general. For lymphoblastic lymphoma in general, you can have B-lymphoblastic lymphoma or T lymphoblastic lymphoma. And in children, the predominant in about 85 to 90% of the cases is the T lymphoblastic lymphoma, while the B lymphoblastic lymphoma only comprises about 10% of the cases. So the leukemia, the most common leukemia in children is B lymphoblastic leukemia. However, the most common lymphoblastic lymphoma is T lymphoblastic lymphoma. As for the pathogenesis for this entity, multiple molecular pathways seem to be affected for leukemogenesis. I'm going to cover that in a separate video and when I talk about the separate entities. As for the histopathology, let me show you a case of a 65-year-old patient who presented with shortness of breath. This patient was tested and the workup revealed a white cell count of over 50,000. And this patient, unfortunately, was found to have a lot of blasts in the peripheral blood. So let me walk you across the bone marrow sample and peripheral blood for this patient. So as you can see here in this field, we do see a couple of large cells, and you can see that these cells are large when you compare them to the surrounding red blood cells. For example, this one here is a large blood cell. Let's go high power, have a look at this cell. This is not actually too large, so let's go around. Let me show you a better example. Yeah, this is a better example here. This cell here in the center of the field is a large cell. It has high nuclear to cytoplasmic ratio. We do have a scant rim of cytoplasm here, which is blue. I don't see any granules. I don't see any like our rods, which are needle-like crystals. Um, and I see a prominent nucleolus. Here is the prominent nucleolus in this cell here. So this cell here is a blast. As for granules, sometimes you can see azerophilic or blue granules in lymphoblasts, like B-lymphoblasts, and these can be seen in about like 10% of the cases, but they're not that common. Let's keep going around. This cell here is very similar to the cell we looked at earlier. It's a large cell, high nuclear to cytoplasmic ratio, scant rim of blue cytoplasm, and I do see prominent nucleoli. For example, this is one here. This is a prominent nucleolus. So I'm going around and I can already spot a couple of blasts here and there. This one here is another blast, same morphology. This one has more cytoplasm compared to the other two that we looked at earlier, but you can see that the quality of the chromatin is similar, and we do have this prominent nucleolus here. Similarly, I don't see any granules, and I don't see any outer rods. So the question is, can you differentiate myeloid blasts from lymphoid blasts? Uh, this can be challenging in so many cases, honestly, because you can see granules in lymphoid blasts, and myeloid blasts sometimes can lack granules and lack outer rods as well. And in these cases, they can be very similar to lymphoblasts. There are certain morphologies that people describe are as kind of being specific. Like, for example, if you have some cytoplasmic blebs on one side of the cytoplasm and it looks like a hand mirror, some people say that, oh yeah, this finding can be seen in B lymphoblasts, but this is as far as you can go. You can say these findings can be seen in B lymphoid blasts or T lymphoid blasts in general compared to myeloid blasts, but it's not a specific finding. Here, this is not the best example for a hand mirror cell, but the general picture is if you have like one cytoplasmic projection here and then the rest is here, it's like someone holding a hand mirror from this side here and looking at themselves, and this is the body of the mirror and this is the hand of the mirror. But this morphology is not specific for lymphoid blasts, and in this case it's not specific for B lymphoid blasts in general. Can you differentiate normal background lymphoblasts from abnormal B lymphoid blast and B lymphoblastic leukemia lymphoma? The answer to that question is no. You cannot reliably make that distinction. It's extremely challenging. There are some features that people look for, but it's really challenging. Another question, can you differentiate T lymphoid blasts from B lymphoid blasts? And the answer to that question is there are no specific morphologic features that we can use to differentiate T lymphoid blasts from B lymphoid blasts. So the furthest that I can get with this peripheral blood is I can say that there is a lot of blasts in the peripheral blood of this patient. Given that we do see a lot of blasts, these could not be normal blasts. Can I tell whether these are lymphoid blasts or myeloid blasts? Honestly, I cannot confidently answer this question. So after looking at the peripheral blood, I'm gonna have a look at the bone marrow for this patient. So let me show you. So as you can see here, I'm gonna go low power, trying to locate a good area, going around, trying to see what's going on. Sorry, let me get into focus. As you can see, this bone marrow aspirate is very cellular. Some rare megakaryocytes here and there. Let me add some oil for better visualization. Let me focus on the screen. Going around, trying to see a speculated area and an area that has better morphology compared to the other areas. Yeah, these areas here are not the easiest areas to look at the morphology. Let me show a different slide. I'm going to show you now the bone marrow direct smear. The direct smear in general has better morphology compared to the speculated one. Let's go to an area like this area here, for example. Now let me add some oil. And let me focus on the screen. Yeah, as you can see here, I do see sheets of large cells. These cells look monotonous. They have high nuclear to cytoplasmic ratio. They have scant cytoplasm. They have prominent nucleoli. Here we can appreciate the morphology. And generally speaking, B-lymphoblasts and B-lymphoblastic leukemia and lymphoma, they can have variable morphology. Sometimes in some cases you can see small cells. And in some cases you can see large cells. Sometimes you can see scant amount of cytoplasm. And in some cases you can see moderate amount of cytoplasm. But the quality of chromatin in most of the cases is similar. So as I'm going around, as you can see here, all of these here in this field, except for this nucleated red blood cell, everything else is a blast. I do see sheets of blasts. Here I do see more blasts as well. So that's the general morphology. So the key points is that differentiation of myeloid blasts from lymphoid blasts can be really hard. Differentiating B lymphoblasts from normal background hematogones is also extremely challenging. Differentiating B lymphoblasts from T lymphoblasts is extremely challenging on just morphology. And because of that, we look at the flow cytometry as well as bone marrow core biopsy, and then we stain the bone marrow core biopsy. Now let me show you the bone marrow core biopsy. Here's our core biopsy, and let me add some oil for better visualization of these cells. Let me focus on the screen. And as you can see here from this magnification, I do see sheets of cells. These cells, even from low power, you can appreciate that some of these cells, like in this area here, they have what we call open or vesicular chromatin that you can almost see through. And even from this magnification, I can see some prominent nucleoli in some of these cells. Let me go higher power to better appreciate the morphology. And as you can see here, I do see these sheets of cells. They have irregular nuclear contours like this one here, this cell here, and this cell here. They have this open or vesicular chromatin that you can almost see through, and they have prominent nucleoli. And just looking at this, I can appreciate that this population is a population of immature cells, but just based on this morphology, I cannot tell if these are myeloid blasts or lymphoid blasts and if these are lymphoid blasts, I cannot confidently say that these are T lymphoid blasts or B lymphoid blasts. But that's the general picture. Also, you can decide on the cellularity for the bone marrow. And as you can see here, the bone marrow is packed, and we estimated the cellularity here by over 95%. There are very rare megakaryocytes, like this one here is a megakaryocyte. But generally speaking, this bone marrow is hypercellular and it's packed with these blasts. Now, let me show you the flow cytometric findings in this patient. And let's have a look here. So as you can see here, we have our CD45 versus side scatter, in which we can appreciate the blast gate here that has this population of dim CD45 population cells here in maroon. Here in green, we have our lymphocytes. Not a lot of lymphocytes in this bone marrow sample. Monocytes, just a few dots here, so very few monocytes. And then here in blue, we have our granulocytes, not a lot of granulocytes. And as you can see here from the number, the dim CD45 population comprises about 91% of the cells in the CD45 positive population. However, remember that we don't use flow cytometry for quantification of leukemia, generally speaking. For further discussion on that, check my video about the blast gate. Now let's go around. So here from here, I can say that we have an expanded dim CD45 population. And I have a couple of questions in mind. The first question is, are these blasts or not? Because some cells that are not blasts can fall within the blast gate. The second question is, if these are blasts, am I dealing with myeloid blasts or lymphoid blasts? The third question is, if I'm dealing with lymphoid blasts, am I looking at T lymphoid blasts or B lymphoid blasts? And flow cytometry is super helpful in answering these questions by looking at the immunophenotype of this dim CD45 population. So let's go around and have a look. So as you can see here, CD34 is positive in this maroon population. So we have a population of dim CD45 cells that are positive for CD34. CD34 is a marker of immaturity. Here we do see our T cell tube that has CD2, CD3, CD5, and CD7. And as you can see, this population of cells is negative for these T cell markers, CD2, CD3, CD5, as well as CD7. Here, this population is negative for CD56. And this population is positive for CD19. CD19 is a B cell marker that is expressed throughout the maturation of B cells. So this is an indication that we might be dealing with a B-lymphoblast population. However, remember that acute myeloid leukemia, in some cases, they can have dim CD19 expression, so it might fall somewhere here in this location. But CD19 by itself, although it's like a sensitive marker for B-lymphoblastic leukemia lymphoma, it can be seen in other entities. And because of that, you want to see more markers to establish B-cell lineage. But from here, so far, what I have is a CD34 positive population that is positive for CD19, which is a B-cell marker, and negative for a couple of T-cell markers that we looked at here. Now let's keep looking. Here, as you can see, this population is positive for CD10. CD10 is an immature marker that is expressed in immature B cells. So the presence of CD10 here supports that this population is a B lymphoblast population. So let's keep looking. CD19 is positive as we discussed earlier. CD20 here is mostly negative, and that's to be expected because B lymphoblasts in general are negative for CD20. CD20 is a marker of maturity, and as immature B cells mature, they start gaining CD20 expression. So the absence of CD20 actually supports the fact that we're dealing with an immature B cell population. Here we have CD38. CD38 is a marker of immaturity as well. If you have a B lymphoblast population that is CD38 positive, then you're definitely dealing with an immature population. However, it's when this population is CD38 positive, it's hard to decide whether this population is a normal background hematogon population or an abnormal B-lymphoblastic leukemia lymphoma population just based on this plot. Of course, you're going to look at the other plots. But what I'm trying to say is that given that this population is negative for CD38, this is an aberrant expression of CD38, and this supports the fact that we're dealing with B-lymphoblastic leukemia lymphoma, because normal hematogones are going to be positive for CD34, and they're going to be positive for CD38 as well, or maybe heterogeneous. So they usually fall within this location here. But the negativity of CD38 supports that this B lymphoblast population is an abnormal population. How did I establish that this is a B lymphoblast population? Because first of all, it's positive for immature B cell markers like CD10, and it's positive for CD19, which is a B cell marker as well. Is that enough? Maybe, but let's have a look at the other B cell markers. And when it comes to B lymphoblastic leukemia lymphoma, you want to see it's not about finding one specific marker, it's the combination of markers that you're looking at that makes you more confident that whatever population you're looking at is a B lymphoblastic population or a T lymphoblastic population or a myeloid population. So let's keep started. But for now, I'm highly suspicious that I'm looking at a B lymphoblastic population. Of course, there's the possibility that there is expression of other markers for another lineage, and in that case, it can be a mixed phenotype acute leukemia. But for now, T cell markers are negative. I do have positivity for B cell markers like CD19. CD10 is positive in this population, and it's an immature B cell marker. So let's keep looking. And as I'm looking around here, we do have our myeloid tube. CD13 is negative in this population. CD33 is negative in this population, and CD117 is negative in this population. Generally speaking, CD117 is an immature marker expressed on myeloid blasts. So given that this population is negative for these markers, that is helpful to exclude acute myeloid leukemia, but the most important marker for acute myeloid leukemia is MPO. So we're going to look at that later. But for now, this population is negative for myeloid cell antigens, which are CD117, CD13, and CD33. However, be careful because B-lymphoblastic leukemia lymphoma, in some cases, can express the myeloid markers like CD13 and CD33. And in that case, it would actually help you to establish that what you're looking at is an abnormal B lymphoblast population compared to normal background hematogones. Here, HLA-DR is positive in this population, and it's a marker of immaturity in general that does not distinguish lymphoid blasts from myeloid blasts. CD123 is positive in about 98% of the cells, and that's helpful. Usually we give a percentage for this because there is targeted therapy against CD123. Here, more of the same. And here we do have our monocytic tube. This CD34 population, which is immature, is negative for monocytic markers, including CD11b, CD14, CD16. CD16 is not a monocytic marker, actually, but you get the point. It's negative here. It's positive in granulocytes. CD64, which is a monocyte-associated antigen, is negative as well. And CD4 is negative in this population. So the bottom line is I don't see expression of the monocytic antigens in this case. And if you have expression of monocytic antigens just by themselves, you should consider acute monocytic leukemia or acute myeloid leukemia with monocytic differentiation in general. Here, more of the same. And now let's have a look at this tube here. And this is where the money is. As you can see, this population is negative for MPO. I said that MPO is the most specific lineage marker for myeloid blasts or for myeloid differentiation. TDT is an immature marker that is expressed on lymphoblasts, whether being T lymphoblasts or B lymphoblasts. And as you can see here, we do have positivity for TDT in this abnormal population. This abnormal population is also positive for CD79A, and CD79A is a marker of B cells. However, be careful because T lymphoblastic leukemia and lymphoma in some cases can show aberrant expression of CD79A. However, in this context, with the positivity of a couple of B cell associated antigens, CD79A presence supports that what we're looking at here is a B-lymphoblastic leukemia lymphoma. And finally, here we have our cytoplasmic CD3. Cytoplasmic CD3 is the most specific marker for T cell differentiation, and it's negative in this case. So what I showed you so far is that we have an abnormal DIM CD45 population. This population is positive for CD34. It's positive for a couple of B cell associated antigens. Whenever we have acute B-lymphoblastic leukemia lymphoma, we have a tube, an add-on tube. So let's have a look at this tube here. And then looking at this tube, this population in red is our DIM CD45 population. So let's track this population. It's positive for CD34, positive for CD10, positive for CD19. Cytoplasmic CD22 is a good B cell marker. It's positive in this population as well. Or you can say DIM. And a lot of the cells are positive here. TDT, which is an immature lymphoid marker, is positive in this population. Cytoplasmic CD3, which is a T cell marker, is negative in this population. And MPO, which is a myeloid-associated antigen, the most specific myeloid lineage marker, is negative in this population. So we're definitely dealing with a B-lymphoblastic leukemia lymphoma. Here, CD20 is DIM in this population, which is to be expected. CD52 is predominantly negative, or it's DIM in this population. And in this context, it's not super helpful, but if you have like bright or very strong CD52 expression, that can be helpful. Apologies, I misspoke. I was referring to CD58. Here, CD52. In this context here, it's negative in this population. Let's keep looking here. This population is like DIM for CD38, but from the previous plots that we looked at, CD38 was negative in this population. So that helps you to decide that this is an abnormal B lymphoblast population. Here we have CRLF. CRLF is a surrogate marker for a gene encoded in B lymphoblastic leukemia lymphoma with BCR-ABL1-like features. I'm going to talk about that in a separate video. But for now, the CRLF is negative. So given all these findings together, we're definitely dealing with B lymphoblastic leukemia lymphoma. So in summary, the immunophenotype Here, the lymphoblasts in B-lymphoblastic leukemia and lymphoma essentially always express the B lineage-associated antigens, CD19, cytoplasmic CD79A, and cytoplasmic and surface CD22, best demonstrated by flow cytometry. When it comes to tissue sections, by IC, PAX5 is the most sensitive and specific B lineage antigen. Cytoplasmic CD79A can also be used as immunohistochemical stain in tissue sections. What you want to see is patterns of antigen expression associated with B cell immaturity. These include dim CD45, CD10 positivity, and in some cases you can have bright CD10, very low to absent CD20, CD34 positivity, and TDT positivity. And that's seen in the majority of cases. There are very rare cases of B-lymphoblastic leukemia and lymphoma that are negative for TDT, but generally speaking, TDT is positive in the majority of cases. As for the diagnostic molecular pathology, based on cytogenetics and molecular abnormalities, there are a couple of subtypes of B-lymphoblastic leukemia and lymphoma that I'm going to discuss in a separate video. And then to make a diagnosis, the essential diagnostic criteria for B-lymphoblastic leukemia include predominantly peripheral blood or bone marrow presentation with demonstration of increased immunophenotypically abnormal lymphoblasts by flow cytometry. And for B-lymphoblastic lymphoma, you want to see predominantly lymph node or extranodal presentation or diffuse organ infiltration with effacement of the architecture by abnormal lymphoblasts. In addition to that, you want to see B cell lineage supported by expression of CD19, CD22, cytoplasmic CD79A, or PAX5 by flow cytometry or IHC. CD19, CD22, CD79A can be seen by flow cytometry, PAX5 can be seen by IHC, and in some labs by flow cytometry as well. You want to see an immature phenotype that is supported by TDT and CD34 expression, but be careful because there are some cases that are negative for CD34 and some cases that are negative for TDT. You want to see positivity or bright CD10 expression, dim CD45 expression, low to absent CD20 expression, an absent surface immunoglobulin light chain expression by flow or by immunohistochemistry. This is something that I forgot to say, which is the surface light chains, namely kappa and lambda, are gained with maturation. They are absent in immature cells and they are present in mature B cells. So you want to see infiltration in the peripheral blood or bone marrow or anodal or extranodal sites. You want to see flow cytometric findings associated with B cells, and you want to see an immature phenotype in these cells. A desirable criteria is demonstration of specific recurrent genetic abnormalities and demonstration of immunophenotypic profiles associated with specific recurrent genetic abnormalities. And that's something I'm going to discuss in a separate video, is that certain subtypes, genetic subtypes of B-lymphoblastic leukemia and lymphoma are associated with certain immunophenotypic findings. However, just remember that this is just an association at the end of the day, and the absence of that association does not exclude the specific recurrent genetic abnormality. Now for the prognosis and prediction. Generally speaking, there is long-term remission rates of over 90% in children with B-lymphoblastic leukemia. However, the benefit in adult B-lymphoblastic leukemia and lymphoma has been modest. So pediatric presentation has a better prognosis compared to adult presentation. Adverse prognostic factors include age, less than 1 year or more than 10 years, an elevated white blood cell count, and that's more than 50,000 per microliter, slow blast clearance with initial therapy, certain genomic entities, like for example, hypodiploidy is associated with worse prognosis, and the presence of residual disease at defined time points early after therapy. Like for example, if you have residual disease at the end of induction or at the end of consolidation, that's associated with worse prognosis, and that's generally the case in most of these leukemias. The presence of CNS disease at diagnosis is associated with an adverse outcome and requires specific therapy. On the other hand, the prognosis of B-lymphoblastic lymphoma is relatively favorable, more so in children than in adults, similar to B-lymphoblastic leukemia. And genomic abnormalities in general are important prognostic factors. This is the end of this video, and see you next time.